discussion here will be including the difference between the expanded hemodialysis, or what's called HDX, versus HDF. فرق ما بين الاثنين and the outcome of both therapy in patients with chronic kidney disease on regular hemodialysis. If you can look here, the difference between HDF and the HDX, still we need a randomized controlled trial. What is the scenario? The scenario here is we have hemodiafiltration therapy, and now upcoming the expanded hemodialysis therapy, and still in the basket more names may come. احنا محتاجين ليه ان احنا يكون عندنا وسيلة علاج اخرى غير ال HDF وتساوي نفس الغرض؟ simply لان ال HDF is more expensive and complicated. Regular hemodialysis is cheaper a little bit, but still cannot be optimized as in HDF. وبالتالي محتاجين حاجة ما بين الاثنين، ما بين ال HDF وال regular hemodialysis، بحيث ان احنا can approach ال uremic toxin removal equivalent للهيمودايفلتريشن. وبالتالي ال HDF is more complex and cost only 20% worldwide can do. لما نيجي نبص على الهيموداياليسيس دوز بريسكريبشن هنلاقي فيه حاجات كتير جدا مسؤولة، زي الفلكس، تايم، الفريكونسي، الديوريشن، ultrafiltration rate and the KT over what. كل ده ليه علاقة ببعضه، ما نقدرش نفصل حاجة عنهم. يعني لو استخدمنا high flux membrane still we are in need of prolonged time, more frequency, controlled ultrafiltration rate, and assessment with a new marker or a marker of KT over V. لازم نتذكر دائما ان الهيموداياليسيس all are in one basket, no one size fit for all patients. ممكن مريض عن مريض بيختلف في الثيرابي. We cannot apply all of them for the same patients. We can differentiate in dose of dialysis according to patient requirements. The multidimensional measure of dialysis adequacy moving beyond small solid kinetics. خلاص الكلام ما بقاش فيه أي لازمة إن أنا أتكلم على اليوريا removal، لأن اليوريميك toxins in the middle molecule range is expanding. عندنا يوريميك توكسين 40,000 و 50,000، اليوريا just 60 dalton. So it's beyond that. We can move from small molecule achievement of dialysis adequacy to middle molecules and much bigger molecules. What is important here is we have to look about the treatment duration, treatment frequency, incremental dialysis in some patients. We have to preserve residual kidney function. We can consider as well in some circumstances home dialysis, looking for maximized quality of life and maximized survival. Note that ultrafiltration rate and extracellular fluid volume management should be applied, as well as removal of uremic toxins. The optimal dialysis dose prescription. ايه الجول اوف ثيرابي؟ لازم يبقى عندي comfortable hemodialysis, better control of blood pressure, anemia, mineral bone disease, better control of uremic symptoms, removal of much of uremic toxins and volume state, and subsequently better survival and health related quality of life. محتاجين عشان نحقق الجول ده high permeable dialysis membrane, high flux definitely, prolonged time, more frequent hemodialysis. KT over V is still the official marker of adequacy. هنيجي نلاقي ان هو في كل الجايد لاينز still looking for urea removal. While 2.2 for patients doing hemodialysis twice weekly and at least 1.3 KT over V per session for patients who are doing thrice weekly dialysis. لما نيجي نبص على الستاندرد KT over V في الباراجراف ونيجي نقارنه بالسيرفيس اريا نورماليزد ستاندرد KT over V هنلاقي ان الومن got less dialysis hemodialysis doses. Subsequently, KT over V, no difference when assessing the volume of distribution of urea. But if we divide the KT over surface area, we found that the females got less hemodialysis doses. For the dialyzer permeability, meaning of a cut-off point, which is equivalent to a sieving coefficient of 0.1, we have low flux, medium flux, high flux, super flux, medium cut-off, high cut-off, as well plasma filter. The cut-off difference between all of them, low flux can remove up to 5,000 Dalton only. Medium flux is less than high flux, but is much better than in low flux. Super flux and the medium cutoff removing much more molecular weight. High cutoff approaching the albumin, and the plasma can remove all plasma proteins. ده diagram يوضح الهيمودياليسيس while using the conventional hemodialysis with high flux. We can remove effectively the small solids, small molecular weight toxins. We can remove as well the middle molecules, but still the protein bound toxins are retained because it's a very big molecule which could not be removed easily by all the hemodialysis therapy up till now. Hemodialysis is a filtration therapy, resampling the glomerulus, and we can remove by the clearance, remove by filtration, and 17% by absorption into the membrane. الفرق ما بين ال HDX or expanded hemodialysis and the hemodiafiltration إن ال HDX بيحتاج membrane permeability عالية وبالتالي remove molecules with molecular weight كبير. هو ال HDF is simply by solid rigging using high permeable conventional high flux membranes. محتاجين ultra pure water طبعا, high flux membrane and high volume convection. ميزة ال HDF and HDX ان هو يقدر يشيل الانفلاماتوري markers وميدياتورز in patient with sepsis. ال HDF enhance the removal by dragging forces, meaning that through the transmembrane pressure can remove bigger molecules. While in HDX with higher membrane permeability up to 45,000 Dalton can remove such molecules with only pi permeability. It's still early to document that in researches, but it's going. We need more randomized controlled trials to compare between both therapy. So the HDX is an expanded range of hemodialysis depend on removal of bigger molecules, as well in HDF, but here in HDF depend on ultrafiltration rates and transmembrane pressure, while HDX depend on only the membrane permeability, removal of middle molecules. في الاكسباندد هيمودياليسيس الالترافلتريشن ريت بيبقى هاي. ده معناه ان في obligatory water loss، وبالتالي for control of blood volume بيحصل what's called back filtration, which is movement of the dialysate to the patients through the dialyzer to compensate for the obligatory water loss. Back filtration volume is risky for pyrogen transfer, so we have to define the water treatment. In HDF, the dose depend on blood volume processed and ultrafiltration and substitution volume. More blood volume and more substitution, you will have a more effective hemodiafiltration. It had been recommended that the dose of hemodiafiltration should be around 23 liters per session. All causes of mortality and free survival improvement with higher doses of KT over V. Improvement in all-cause mortality in HDF therapy, and it's dependent in doses. So increasing the dose improves the survival. When looked to that, below 21 liters, there is nothing improvement in survival, except if we can move toward 23 liters. Above that, no significant changes in survival. That's called high efficient online hemodiafiltration. Hemodiafiltration depends on blood flow, extensive ultrafiltration making a high blood viscosity, subsequent increase in transmembrane pressure, and depend on dialyzer characteristics. In hemodialysis machine, there is a feedback control, meaning that مع زيادة في الالترافiltration through the all lengths of the dialyzer, there is hemoconcentration and protein concentration. Makes the membrane to be closed, membrane to be fouled by proteins. In some hemodialysis machines, there is back filtration on demand. When the transmembrane pressure increase, the machine start to push dialysate from outside to the blood side, so cleaning up the membrane and returning back to its efficacy. That's called back filtration on demand. على الناحية التانية الهيمودايفلتريشن بنلاقي ان HDX is more simple technique, needs regular hemodialysis machine. Hemodialysis membrane progression over decades هنلاقي ان في since 1980 low flux, some high flux in 90s, high flux membrane and some albumin leak. Nowadays there is high performance membrane and the medium cut-off membrane allowing for removal of some albumin. The pore diameter between low flux and high flux, and the difference between high flux and high cut-off ما بين الاثنين هو الميديم cut-off membranes. هنيجي نلاقي ان الهيمو dialysis using the medium cut-off يقدر يشيل more uremic toxin in molecule than in regular high flux membrane. في زيادة في البور diameters، وده مصاحبه أكيد some more albumin loss. So the medium cut-off membrane closer to the natural kidney removal function. Removal of more toxins up to 45,000 Dalton. Removal depend on the sieving coefficient of the dialysis membrane. Bigger pore remove middle molecules as well albumin. So the expanded hemodialysis, meaning that expanded than conventional high flux removal, medium cut-off membrane show permeability close to that of the natural kidney. Calculation based on in hemodiafiltration and the medium cut-off on the ultrafiltration and sieving coefficient of the solids. In HDF نعتمد تماما على الالترافiltration rate and the substitution volume. The risk is more albumin loss in medium cut-off من 3 ل 7 جرام and in high cut-off above 7 gram per hemodialysis session. But we have much improvement in removing of molecules, big molecules like free light chain, kappa and lambda. Complement, myoglobin, beta-2, microglobin, all are efficiently removed by HDX, medium cut-off, high flux, and hemodiafiltration with superiority of HDF and HDX. Higher clearance and the higher albumin loss. We have to remember that. Improvement in beta-2 microglobulin removal. Improvement in middle molecules. Even the clearance of free hemoglobin is high. Potential benefit, greater clearance of kappa and lambda, limited effect on protein bound toxins, down-regulates the expression of both interleukin 6 and tumor necrosis factor, removal of soluble mediators, and transcription of pro-inflammatory cytokines in peripheral leukocyte is markedly reduced. ناخد بالنا ان الالبومين loss in conventional high flux is below 0.4 gram, while in HDX or expanded hemodialysis approaching from 3 to 7 gram. Clinical outcome, some trials, improvement in cytokines removal, but drop in serum albumin is respected. We have to look about that for the nutritional state of the patient. It's exactly to remove more uremic toxins as well cytokines. Myoglobin and beta-2 microglobulin differences between HDF and the medium cut-off hemodialysis are nearly the same.